Good morning. Thank you very much for inviting me, and I enjoyed Ola's talk very much. The question is, does it matter if you don't want to cure, if you just want to control, right? So, we know a lot about high-risk myeloma, but I think we don't have a direction. High-risk myeloma has been defined in many different ways. In the early days with metaphase karyotyping, high LDH has long been recognized as an indicator of extramedullary disease being high risk. Extramedullary disease is best identified by PET scanning, and we and others have put a lot of emphasis on gene expression profiling of purified plasma cells from the bone marrow with all the caveats that Dr. Landgren pointed out. So this malignant multiple myeloma is a problem, as we have did perform gene expression profiling or gap studies beginning with Total Therapy 2 and then applied in subsequent trials that included bortezomib. We have found that good progress, excellent progress indeed, was made among the 85% of patients presenting with low-risk disease, but little, if any, progress was noted among those 15% who de novo have, in the 70 gene model, in our case, high-risk disease. We then began 5-6 years ago recognizing that little progress had been made in high-risk disease, so we actually used the gene array to assign patients to different protocols. Low risk got Total Therapy 4, high risk Total Therapy 5, and here we emphasize dose density rather than dose intensity in order to be sure that patients could get the prescribed therapy on time so that there wouldn't be too lengthy periods where the host required long recovery time during which the tumor escape was then noted. And this is a brief outline of this. Induction therapy, we do pharmacogenomic studies after bortezomib and low-dose melphalan in order to get a handle on this intratumoral heterogeneity. And then we use these hybrid transplants, fractionated melphalan with bortezomib, Revlimid, and PACE, and so on. Characteristics are listed here in the first 60+ patients. And as you can see, metaphase cytogenetic abnormalities were present in 2/3, where in the overall population, it's just 1/3, and in low risk, probably 28% or so have cytogenetic abnormalities. Highlighted under the in the bottom part in terms of gene expression data, the MS, that is the FGFR3 or MMZ group, is overrepresented in high risk, as is the proliferation molecular subgroup. And underrepresented is the CD1 group with co-expression of CD20, which we refer to as CD2 group, and also the low bone disease group. The outcomes are shown here on your top left, the progression of patients through the different protocol phases. Top right, the timing of onset of various response levels. In green, complete response. The stringently defined complete remission is somewhat of a difficult issue, as immunofixation studies can just fluctuate. You have one day you have a positive, next one you have a negative result, And I think that's a little bit overrated probably. And then the bottom is the survival and progression-free survival, and green is the timing on study. Then we looked at traditional outcome variables at baseline in this high-risk population, notably on your left panel, causes of death. There was only one treatment-related mortality with this generally very well-tolerated regimen. In blue, you can see mainly myeloma-related death. Age, LDH, and cytogenetics really didn't play a major role. There was a trend for elderly patients to do worse, and the study was open to patients up to age 75. Progression-free survival, same story. On your right bottom, molecular subgroups, and there are just too few in each of these 7 subgroups to draw conclusions. Then we looked at another prognostic model. We noted Dr. Heuk in our program found that 5 out of the 70 genes constituting this risk model were particularly important. And you can see here on your bottom left that patients who fall into this lowest tertile for the GEP5 model had a significantly better outcome. Then we looked at the high-risk population treated with bortezomib-containing therapy in total therapy 3 vis-a-vis total therapy 5. And you can see that the major features were basically the same. I'm highlighting on the bottom the presence of cytogenetic abnormalities, and within the GEP70 high risk, about 70% of patients were also deemed to have high risk in the refined GEP5 model. Here you see the outcome in terms of overall survival on your left upper panel. We see that total therapy 5 patients did better in terms of survival than their predecessors receiving total therapies 3A and B, with the difference between A and B being that lenalidomide was given in the B portion for 3 years, along with bortezomib for all 3 years. Then we combined the high-risk patients defined by GEP70 of total therapy 3 and 5, and you can see that the GEP5 model, the risk score, identifies and peels off patients who do better in red, and then in the high-risk model in blue. We performed a Cox regression analysis for outcome. Univariately, the GEP5 risk played a role, but in the multivariate analysis, it was total therapy 5 was the winner for overall survival, and also to enter and sustain complete remission for 3 years, as we had previously published, was very critical. And as Dr. Landgren pointed out, we and others are doing serial MRD testing. We have the same experience. We don't any longer know which sample should go for what first. We think the cytogenetics are important, the gene array is important, the MRD, if that is the last sucker, number 7, you will have a negative result. And I like the idea of studying peripheral blood very much because it's reproducible and potentially encompasses all the things that Dr. Landgren already talked about. And one of the hypotheses that we are pursuing is the failure for high-risk disease to be eradicated and to enjoy a long progression-free survival due to lesser tumor site reduction or just rapid regrowth, and probably both of these issues apply. Here you can see the GAP70 high-risk outcomes, overall survival, top left, progression-free survival, complete remission duration on the right bottom, among the patients beginning with total therapy, with and without thalidomide, who had gene expression data. And you can see while there is some improvement in progression-free survival, when you look at the curves on your upper right, the blue and the red and the purple are sort of the same, and then there's some improvement, but the only improvement in survival was seen with total therapy, 5 in gray. Once patients fail to and progress on with their high-risk disease, their subsequent survival is dismal, as you can see here. Now I'd like to address the cure issue. There's always got to be cure, right? And it's kind of interesting if you focus on the left bottom panel. I tell patients who present with high-risk disease that if they just make it through the first 3 or 4 years, their subsequent probability of incurring a relapse is actually very low, analogous to the story in high-grade and low-grade lymphoma. So the inflection point that you can see with high-risk disease is at around 5 years, whereas with low-risk disease, you have to follow the patient 10 and more years in order to be certain that a plateau has been reached. And this is very similarly seen here for the successor trial, Total Therapy 3. So when a patient has made it without a recurrence, presenting with high risk, even with extramedullary disease, and the patient is disease-free 5 years out, the probability of a subsequent recurrence is very low indeed. So that GAP5 model, we have applied this to the low-risk protocol Total Therapy 4 and the high-risk Total Therapy 5 on your right. And you can see that one can peel off a favorable subgroup within low risk, but defined by GAP70 in Total Therapy 4, and one can define an ultra-high risk group among the Total Therapy 5 population. This topic has already been discussed by Drs. Morgan and Landgren earlier, and it's a really important issue. And we set out, when we started Total Therapy 1 in 1989, we felt that there were so many different subclones probably present, like in solid tumors, that we wanted to bring to bear all we had from the outset in order to fulfill a potential objective of cure. So high-risk myeloma is the final pathway of treatment failure. I think there are huge dividends if one finds effective therapy, whatever it may be, for this high-risk, de novo high-risk disease, because when it works there, then you can go back and apply it to low-risk disease as well. Leif Bergsegel and I have discussed many years ago the issue whether high-dose therapy with or without transplantation might actually be a negative factor, because you release a cytokine storm in order to allow normal hematopoietic recovery, and those very cytokines may also support the recurrence and survival and recurrence and progression of myeloma. This led us to investigate metronomic therapy. This was recently published in Hematologica by Xenophon Papanikolaou, and we have extended this to a 28 course of very low doses of doxorubicin cisplatin with bortezomib, thalidomide, and dexamethasone. We have begun to identify actionable gene mutations, and this is the first patient who did have a KRAS mutation, and you can see that the institution of trametinib in this higher risk setting was associated with a transient reduction in the serum light chain marker. Patient since has progressed, but he is responding to other therapies. Dr. Hoy gave me this slide last night. So we have submitted 67 samples from 67 patients to Foundation 1, and you can see there's actually a high incidence of actionable mutations, and they are listed in their order of frequency in this slide. Dr. Van Ree had a patient recently whom he treated with a combo, and it included ipilimumab. Got this out right, and you can see on a PET scan within relatively short time, that is within 2 weeks or so, there was huge improvement in the PET scan. Extramedullary disease, or EMM, extramedullary myeloma, is really an issue that we are confronting every single day more and more. And the problem is that, and the consequences of this extramedullary disease presentation at the outset is delineated here among all patients who underwent transplant interventions at our center. And you can see their median survival is indeed only a year, but then it levels off, and whether or not there's a plateau is to be seen. Then we looked within total therapy, that is frontline trials, in terms of low or high risk. You can see that de novo, the high-risk population has a higher frequency of extramedullary disease of about 6% versus 2% in low-risk disease, but then it eventually increases. And when we looked at logistic regression in order to see which variables were linked to the presence of extramedullary disease, you can see that there are only genomic variables entering, notably MAF-B, the proliferation subtype, and the centrosome index. I think Dr. Fonseca introduced that variable. We then tried to determine whether, upon examination of purified plasma cells, we could then see whether a signature in the marrow could be recognized that distinguished patients who presented or who would develop extramedullary disease seen on PET scanning. And you can see in the red bars, they sort of cluster together, but we have also gene expression data from extramedullary sites, and this is under intense investigation, but I don't have the data yet. How to move forward in extramedullary disease? We are using on a PEC-Med regimen that is delineated, and then on day 4 we repeat a PET scan. If the lights are not out enough and the patient handled the treatment well, they get another shot of melphalan, 50, 75, or 100 milligram per meter squared. And the challenges are that the extramedullary disease often does not have secretory activity. and we need to perform repeat PET scanning, and the guidelines, insurance guidelines, Medicare guidelines say you can only do 3 PETs in a lifetime. Well, we have done as many as maybe 20 in a year. And so this is another major issue. We try to individualize according to the level of FDG suppression, which we published also in newly diagnosed patients. Dr. Bartel did this in Blood, made the cover of Blood actually, and we have since found that even a day 7 suppression, especially in high-risk disease, day 7 of induction therapy has major implications for outcome. Is there heterogeneity among different EMD sites? The most preferred extramedullary site is the liver. And the question is, does this have something to do with hepatocyte growth factors? Can this be recognized in the peripheral blood? Are these different mutations that have a predilection for liver versus retroperitoneum and what have you? And those investigations are in progress, and I thank you for your attention.